Hi, it's Terry Kuti of Deep Sea Foundation. We're here to have a conversation to help patients in consultation and care through their decision process for treatment, surgery, recovery, and on to survivorship. If you're a surgeon or healthcare provider listening today, please hit the pause button if you need to take notes. These are surgeons who have built a footprint of success for their patients who they care for who are affected by breast cancer. I want to acknowledge the ARSA, that's the Advanced Reconstructive Surgery Alliance Network, and their leadership for allowing this time and space for me to make these interviews for you, the listener. Please share them with those who you feel can use this information. And I will have contact information for you to reach out to an IFAR surgeon, or in the case of Dr. Suarez today, who I am interviewing, the Premier Surgery Network of Surgeons. And that information will be at the end of the video in the credits. So with that, let me introduce my guest. I'm talking to Dr. Adrian Suarez, who is a board-certified general surgeon, certified by the American Board of Surgery, and a fellowship-trained breast surgeon. She completed a surgical oncology fellowship training at Emory University. That's in Atlanta, correct?
Yes.
Correct. Yeah, in Emory University School of Medicine. She's an active member of the American College of Surgeons and the American Society of Breast Surgeons. Dr. Suarez practices at North Bergen and Westwood in New Jersey as part of, as I said previously, the Premier Surgical Network of Physicians. So Dr. Suarez,
Yes.
Thank you for joining me today.
It's a pleasure.
I am a former ESL trained teacher, so I have a really interesting question for you that's just really passionate about the work that I do too in this space for patients. And I know that you are committed to advocating for patients. So how, in a world of breast cancer, we have so many terms that we have to learn and understand about breast surgery, breast treatment. How do you facilitate those conversations with those whose first language is not English, because you are a Spanish speaker yourself?
Yeah, so I am a Spanish speaker, so that does help
Yes.
with those conversations.
Yes.
But even with patients that don't speak the language that I speak, so I speak English and Spanish fluently.
Yes.
It's important to facilitate especially the initial conversation about a breast cancer diagnosis in language that the patient can understand. And that doesn't necessarily mean just in their language of choice, but also in words and verbiage that are more understood
Yes.
by a patient.
Yes.
Because like you said, it's complex. Breast cancer gets more and more complex
Yes.
as the years go on and as research advances. And I really think it's important for the patient to have that information themselves, to know what their diagnosis is, what their treatment options are, the team that's going to be involved in caring for them, and that they feel empowered in that knowledge to make further decisions. And sometimes that's done speaking Spanish. Sometimes it's Haitian Creole with an interpreter. But the important thing is that understanding between the doctor and the patient.
Yes. So you brought up a really important point I'm going to segue into also. You are not the only doctor they see. And you mentioned coordinated care.
Yes.
That is a challenge not only, I think, for patients, but also for surgeons. And, by coordinated care, we're talking about oncology, radiology, physical therapy, could be a whole team of doctors. And, really, Dr. Suarez, I doubt that everybody that comes to see you may be from the area. They might be going to different doctors, different hospitals? How is all that coordinated?
Well, it's important for number one, I chose to follow this career path because I loved the idea of working with a multidisciplinary team, working with other doctors, collaborating on that one patient. So for me, that was a draw. But for a patient, it can be confusing, right? You come to the breast surgical oncologist, and I go through the care plan with them. But that care plan involves, like you said, medical oncology. You will be going to see the medical oncologist. This is what that doctor will discuss with you. You will be going to see a radiation oncologist, and these are the things that that doctor will discuss with you. Like you said, physical therapy, nutrition, genetics. There's so many elements of that multidisciplinary care team. And I like to give the patient a roadmap of what's ahead. But it's important for my team, which includes even a breast navigator. I think the breast navigator plays a huge role in breast cancer care because, well, just like the title says, they are navigating the patient through that spectrum of care, through the multidisciplinary team, which could be in multiple hospitals, in multiple cities. Hopefully not.
Yes,
preferably
but sometimes is.
Preferably it would be in the same center, but sometimes that's not how we can have it done. So that's coordinated with the navigator, with a very robust team that I have.
It's interesting to me that you mentioned the nurse navigator, because I felt very fortunate that I had one myself, and I never think it hurts to ask if they have nurse navigators within a system, no matter who you're going to.
Agree.
Yeah.
I think that's very important for the coordination of care of the patient.
Yes, I do too. And, it probably becomes, I'm thinking, a trusted source for them to lean on, because they know that you guys have such full schedules. You're in and out of clinics, you're in and out of surgery. So to have that one person too, to know that they can go to.
Yeah, definitely to have the point person. But I just remembered what I was going to say before, and it was about that multidisciplinary team. So even though we are scattered, perhaps not in the same hospital system, even if you're in the same hospital system, you're not in the same office, you're often not seeing the patient at the same time. But we do have meetings where we discuss each patient and their complete care plan. So that's how we coordinate care, and we discuss each patient.
Yeah, similar to tumor boards?
It's tumor board.
It's tumor board, yeah. Yes, I remember that. You treat a number of breast symptoms, some of them benign breast disease.
Yes.
So I'd like for you to speak to us a little bit about what some of those are. When should patients be concerned, what follow-up care is, etc., and maybe a few types of those benign breast diseases.
Okay. So I think one of the more common benign breast diseases that I see that causes the most anxiety is breast pain.
Breast pain.
Breast pain is very common among women. It is not generally, and I would say majority of breast pain is not caused by an underlying breast cancer. But the anxiety that it produces for the patient is extreme. So I do see a lot of breast pain, which I manage expectantly with symptomatic management. So I like non-inflammatory gels they can apply, warm compresses, cold. This is after getting imaging that shows there's no underlying disease, doing a clinical exam, full history, risk assessments. Once it's just breast pain, then it's really just symptomatic management. A lot of women don't wear the right bra. That can often cause this breast pain. Stress, caffeine intake, little things can lead to big worry for patients. So that I see a lot of. And then when we get our mammograms and our ultrasounds, we find stuff in the breast, and those are often benign.
Yes.
The majority, 80% of them are going to be benign.
80%.
Yeah, very high number. So generally it'll be cysts. There are solid tumors of the breast called fibroadenomas, which are benign. Don't always have to come out. They do need to be seen, I think, by a surgeon so that I can ensure that those masses, whether they're solid or cystic masses, are stable over time. They're not changing. Because when we get a mammogram or ultrasound, it's an image. It's a static image of one point in time, but we want to make sure over time things aren't changing.
Right.
And I mentioned before that I do risk assessment for patients because, we hear, especially during October, Breast Cancer Awareness Month, we hear 1 in 8 women will develop breast cancer. And that is true and not true because I might not be 1 in 8 and you might not be 1 in 8. Our risks are different. Our family history is different. Our other risk factors for breast cancer are different. And so it's important for each woman to know not only their body, know changes in their breasts and their nipples and the skin around that area, but also to know what their risk factors are.
Yeah, that's a really important thing that you bring up. And I think, too, the monitoring over time, especially when they have breast pain or they have these benign breast diseases, keep track of the changes. Know thy own body.
Yes. Best advice.
Absolutely. Well, I want to ask you about a topic that is frequently asked of me in my community, and that's about who is a candidate for skin-sparing, nipple-sparing mastectomy.
Okay.
You ready to tackle that one?
Sure.
Okay, because, I just get varying degrees of concern about that. If a woman, I'm just sharing my own personal conversations that I've had with some women, which I'm sure you have the same ones in your clinic, but sometimes they'll say to me, they'll go, I have breast cancer, I just want everything gone. I had skin-sparing, nipple-sparing mastectomy. It was very clear to me before I went into surgery if she could or couldn't do it and what she was going to do her best to achieve. I'll leave it at that and let you answer the question.
So when you say skin sparing, nipple sparing, I think you mean nipple sparing. Because skin sparing, the nipple is removed. The nipple and areola are removed, but the majority of skin is spared to facilitate reconstruction later.
Thank you.
And for the majority of patients with early stage breast cancer, a skin sparing mastectomy followed by reconstruction is appropriate.
Yeah.
Where skin sparing wouldn't be appropriate if there's skin involvement and that skin then cannot be spared.
Yeah.
But the majority of women can have a skin sparing mastectomy. Now, in the setting of nipple sparing mastectomy, so now this is all the skin is spared as well as the areola and the nipple. It's important to know, though, that skin and that nipple and areola are insensate. So you have the illusion of the skin and the nipple, but there's not the sensation, the sexual sensation or the erotic sensation is no longer there. There may be pressure sensation, but it does come with a very good cosmetic result if you can spare the skin and the nipple and areola. So when is that appropriate? It's appropriate when obviously the nipple and the areola are not involved with cancer. Or the proximity of the cancer to the nipple and areola is enough that you feel, or the surgeon feels, like your surgeon said to you, I'll do my best. That you can safely get around the breast tissue with a good amount of healthy tissue between the cancer and the skin and the nipple.
Talking about blood flow now, right?
Well,
I mean, that's
the blood flow has to definitely be there. You don't want dead skin.
Right.
So you do need to have healthy, vitalized skin. But also you don't want the cancer to be so close that you're taking a risk for cancer recurrence.
Exactly.
So,
what is there a measurement they look for? But it probably depends on the stage and grade too, right?
It depends on a lot of things. So the type of cancer, is it in the ducts? Is it a solid mass? They're used to say 2 centimeters, but that was a long time ago. Now it's really, I think, at the surgeon's discretion. Can you get an adequate margin between the tumor and what you're leaving behind? Because a mastectomy, you're leaving behind very little breast tissue.
Right.
You're still leaving some. There are still cells along the skin. But you want to make sure that you can do a good oncologic resection, so good cancer surgery, and still leave the patient with a great cosmetic result.
Yeah.
Those are the goals.
Yeah. So just sitting with you and talking with you, I can tell, I get this warm vibe from you, Dr. Suarez. What does it mean for you when you have a patient and you see them through their surgery, but you see them beyond that to survivorship?
It's the best. So my patients are the best. I mean, so grateful. I get to see them. I see them for many years after they're cancer-free, through their recovery and into survivorship. And we form bonds. I mean, I have patients that I just recently came up north from more central Jersey to up north to practice. And many of those patients came with me, like followed me. And I have one that just visits me on my birthday, not for an appointment. She just comes to say happy birthday to me because we've bonded, we've become friends, almost family. You go through a period with them, it's their weakest point. They come to me, there are tears, there's fear, anxiety, and then there's celebration later. And so that is a bond I am so grateful I get to have with these women.
I think it's what gets you up in the morning, isn't it?
Oh yeah, 100%.
Yeah. So there's a little mist in both of our eyes as we're both sitting here talking, because I could tell this about Dr. Suarez when I was reading her bio. So it's just delightful to be able to interview you and take me back to when I sat in front of my breast surgeon. It's a good feeling to have that bond. I always tell patients they know when that trust is formed in consult. And so it's just lovely to talk to you and interview you. Thank you for the great information today too. And like I said, this is Dr. Adriana Suarez, and she is with Premier Surgical Network of Surgeons. We'll have more information at the end of the video for you to get in contact with her or another surgeon. Thanks so much.